Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Tara Harrington, our Trauma Program Director at RUMC, and Dr. Vladimir Rubinshteyn, Trauma Medical Director at RUMC. Through RUMC Connections, you'll meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. So trauma is the leading killer in patients under age 44. So trauma services involves the detailed assessment and care of injured patients. Richmond University Medical Center is a New York State Level 1 adult and Level 2 pediatric trauma center, which is the highest designation given for trauma centers. RUMC's emergency department is accredited by the American College of Surgeons, which means that RUMC services adhere to rigorous standards, ensuring the highest quality of care, including the ability to treat a high volume of patients 24/7, 365. RUMC also has board-certified subspecialists available in the areas of emergency medicine, orthopedics, neurosurgery, anesthesia, and plastic surgery to help care for injured patients. RUMC's trauma service also provides cutting-edge intensive care for injured as well as surgical patients. Today we'll be discussing the critical importance of the golden hour, which is the first 60 minutes after a traumatic injury. We'll highlight the protocols, rapid assessments, and life-saving decisions made by the trauma team during this crucial period. Trauma Medical Director Tara Harrington and Trauma Medical Director Dr. Vladimir Rubinshteyn will illustrate how RUMC maximizes this window to save lives. So Tara has been the Trauma Program Director at RUMC for the last 2 years, but has been a nurse for 34 years, with most experience in the emergency department and administration. Tara holds a master's degree in nursing. Dr. Rubinshteyn is the Trauma Medical Director, and he has 17 years of experience as a trauma surgeon, so he's seen it all. He's a fellow of the American College of Surgeons. Dr. Rubinshteyn completed medical school at Temple University, and his residency was with Staten Island University Hospital, followed by a fellowship completed with New York Presbyterian while Cornell. So let's dive into this golden hour. Can you explain what it is and why it's so critical to trauma care?
Right. I think that's a very good question. And, golden hour, it's an interesting concept. It's a little bit of a misnomer, because it's actually not an hour.
Yeah.
We say golden hour, but what actually that means in the trauma, trauma is very specific in a way that it's really time sensitive. This is one area of medicine. Time really matters. And the golden hour is not actually an hour. It's just the idea that the immediately life-threatening problems that patients come in with, they have to be addressed right away. It's not really an hour. It's just whatever needs to happen right away. And the idea behind it is that you have to treat those life-threatening injuries as soon as possible. Mm-hmm. So that's kind of like a little bit of a misnomer, but that's the idea. It's just you approach the patient with the most urgency.
So what inspired you both to specialize in trauma care, especially in such high-pressure scenarios?
I think for me, I enjoy the fast pace.
Yeah.
And I enjoy using critical thinking to make a difference. And I think for trauma, there is that initial, when they first come in, that very intricate, very immediate time where what you do will affect the outcome of their stay. So for traumas, most people, it's something that was, well, for everybody, it's an unexpected. It's a car accident, or it's a fall, or it's something that could change. Potentially change the trajectory of their whole lives. So being there and being able to help them through and seeing them, have a really good outcome because of the care that we gave, I think that's why, for me, that's why I come back all the time. That's why I like it.
How about for you?
Trauma is great. I mean, it's interesting. It's you have immediate effect on somebody's life.
Yeah.
I mean, I chose surgery because of that immediate effect, because, in medicine, things can get a little bit slow. You give medication and, you wait for the effect. And, for me, I don't have patience. So the most immediate effect you can get, I think, isn't really in trauma scenario when you immediately, can save somebody's life. And,
yeah.
So to me, that's great. And I like the fast-paced environment. So.
Yeah, I'm sure no 2 days are ever alike, right?
No, you never know what's going to come through the door. Yeah.
You never know what happens
Exactly.
next.
Of course.
Exactly.
So, all right. So, what are the key steps that you take when a trauma victim comes through the doors?
Well, I think it's really the assessment of the patient first and exactly what happened, what the mechanism of injury was, and how we activate the trauma team. So there are levels of activation.
Okay.
Level 1 would be the highest activation that you would see somebody, it's life or limb. It's everybody comes and we make sure that the operating room is available, that there's blood products available. And you have to assess the patient as they're rolling in the door. You have to listen to the story. And then there's a plan that's to be made. So the trauma surgeon arrives and they're in collaboration with the emergency department physician. They make a decision as to what the next steps are and what's going to happen with the patient, if they're going to need to go to the operating room, what kind of testing they're going to need to do. The nurses are there to make sure that the patient has IVs and blood work, and they're on the monitor and vital signs and things like that. So for us, the preparation really is making sure that you have all of the trays available, anything that you think you're going to need for when the patient comes in, knowing the mechanism of injury. We like to get a little heads up from the notification from the EMS to tell us what it is so that we can prepare.
Yeah.
And the operating room can prepare if they need.
I work in trauma bay, by myself. It's not going to be easy. I have nurses, I have techs helping me, radiologists. My residents are there, emergency room physicians. So it's really a team effort. The first steps when a patient comes in, obviously, it's rapid assessment. And, like I said before, is the life-threatening injuries such as punctured lung, pneumothorax, hemothorax, hemorrhagic shock. So those are diagnoses that have to be made in the primary survey. And really, you probably have maybe 5 minutes to make those diagnoses, maybe 5-10 minutes. You have to make those diagnoses. Once you make them, then you have to make a decision what you're going to do about them.
Can you walk us through a real-life scenario where this golden hour made, a difference in saving a patient's life?
Right. Well, once the patient comes in, just like I said just now, you're looking for those diagnoses. So, for example, last big trauma case that I had was actually pain-trained trauma, was a gunshot wound to a patient's abdomen. So at that point, if somebody comes in, for a trauma surgeon, the biggest decision is obviously the decision to operate on the patient. And generally, when somebody has a gunshot wound to the abdomen, the decision is pretty straightforward. So that somewhat makes it easier. But that patient comes in, we immediately resuscitate the patient, meaning that we place IVs, we intubate the patient, and we bring the patient to the operating room. This is the golden hour. This is actually golden minute. The sooner you get the patient to the operating room, the sooner you're going to get control of the bleeding. The best chance the patient is going to have of survival. Because obviously, the patient comes into you. You don't know how much time the patient spent in the field, how much bleeding is taking place.
Yeah.
Trauma surgeon's life's motto is stop the bleeding. And
do patients like that typically need blood transfusions from loss of a lot of
yeah.
blood?
We start that right away in the emergency department when they're there. I think there's a collaboration that you would kind of looks like chaos, but you wouldn't believe. Everybody's doing what they're supposed to do. So there's the nurses are doing what they have to do. The blood bank is there. The operating team is aware. They know, the operating room knows what to prepare for. Respiratory is there. Everybody's around and everybody's doing what they're supposed to do to make sure that we get a good diagnosis and that we get the patient where they're supposed to go. So we've had a lot of success. We've seen patients come in really stabbed, shot, car accidents, and they take them to the operating room and they save their lives. It is minutes count. Every minute counts for these patients, and they're lucky that I always feel like these patients are lucky that they come here because we have a lot of talent. And we have a lot of seasoned people that come there, and they save their lives.
Absolutely. No, couldn't agree more. It's a fantastic team. So how do you know who should respond to the different types of traumas at RUMC?
Yeah, that's the activation criteria that we have, and we actually go through that criteria quite often, and we make sure that we don't have an over-response and we're not wasting resources, but yet we have everybody there that needs to be there. So we collaborate with the emergency department and with all of the physicians to make sure that this should be an activation, this should be a level 1, this should be a level 2. So when it's a level 1, like I said, everybody comes, maybe a little bit more than we need sometimes, but everybody comes just to make sure that they're not needed. And then we have a little crowd control. We're able to, get the patient where they need to go without having any issues. And then level 2, we still need everybody there, but not as many. That's usually something that is and actually that's our highest activation at RUMC is our level 2.
Level 2.
So everybody knows exactly what they're supposed to do and we know where they're supposed to be. And then we have a level G because we do have a high population of geriatrics that come.
Okay.
So we needed to do something geriatric specific. So if you call a level G, it's usually somebody that's 65 or older, and they come with comorbidities. They come with a lot of different polypharmacy and things like that. So we have people there that are able to step in and help us with the diagnosis, keeping that in mind.
Yeah.
So everybody, because we have the activation criteria, it's very straightforward as to who should be there and where they should be and when.
That's helpful when every minute counts, of course. Okay. So are there any misconceptions you would say about the golden hour that you maybe would encounter from the public or the media?
Well, I think people don't realize how important it is to get right away the care that the patient needs. Do I think that there's misconceptions? I think that people maybe sometimes people overdo it. In trauma, you can never overdo it, really, when you think about it. They have to get there, and they have to get there fast. So I think that people don't realize all that has to be done. And sometimes they don't understand the severity of what took place. It isn't until they get to the hospital that we really, act on it as quickly because we realize that, potentially there could be so many other issues that happen with the patient. So I think the misconceptions, if there are any out there, it's just to get them to the hospital. Don't just sit on it. Get to the hospital quicker than sooner rather than later.
I agree. As the trauma program director, how do you ensure that the team is ready to operate seamlessly?
It's a lot of collaboration with all different areas. I mean, we start with EMS and the emergency department. We work with the lab and the operating room and the PACU. It's a lot of collaboration, but I think most importantly, it's education and it's looking at what we did and how we can do it better the next time for the next person. Maybe we did something that we really liked and it improved the patient's outcome, or looking and saying, next time we shouldn't do it that way. So I think it's really all about education. It's about looking at the and debriefing the trauma that we had and making sure that everybody felt like this was done correctly, or next time we're going to do it that way. So I think there's a very big collaboration in trauma. I mean, it really touches almost every department in the hospital when you think about it.
Oh, I can imagine.
And we get them from the incident, we get them right through to get them into rehab to reacclimate them back into their lives. So it's going through the whole program, which is really a positive for the patient, I think. And I think a lot of people don't realize that it does touch, you could even, you're still a trauma patient when you go onto one of the floors. Just because you're not in the ICU or just because you're not in the emergency department doesn't mean that you're not a trauma patient. It goes throughout the entire hospital stay.
Absolutely. Okay. And what role does pre-hospital care, such as EMS, play in optimizing this critical time window?
Yeah, I think EMS is very important.
Yeah.
They bring patients to us, and I think they do a very good job. The idea is that the most interventions should not be done in the field, meaning that the best way to practice scoop and run, you pick up the patient, you bring patients as soon as possible to a trauma center. They will do some interventions that they're trained in, and they're very good.
Yeah.
I mean, they're really good people, and we know them pretty well because it's the same people that keep coming to the hospital. We have some personal relationship with them.
Yeah, we meet with them a lot, and we have a liaison in the emergency department. She's really very instrumental in giving policies and procedures and things like that. I mean, they're really the ones that are at the scene. They're the ones that actually they saw the car, they saw where the airbag was, they saw where the patient was seated in the car. And so when they come in, you have to listen to their story because they were the ones that were there in order for us to make a really, for the doctors there and the nurses to make a really good decision as to what to focus on. So they play a big role, in it. And we, even the New York City Fire Department, EMS, Dr. Rubinshteyn has met with them and their medical director as well, just so that we're kind of on the same page as far as scene time and things like that, just to get them to us as quickly as possible because of the golden hour, because we want to make sure that we can get them as quick as possible. So scooping and running is really the best way to get them to us, fast.
And I'm sure, like you said, they provide so many critical details
They do,
that really help with your
just
next
where the
steps.
patient was seated in the car, how fast the patient was going, did the car was going, did the airbag deploy, or were they thrown? That makes a big difference. Were they hit, are they 5'2" and hit by a Cadillac Escalade, or were they 6'3" hit by a little Honda Accord? It makes a difference where you're going to look for the trauma. So
There's a timeout. I mean, there's actual structure. So when they bring the patient in, there's a timeout, and they actually give us a sign out, which is maybe 30 seconds, where they tell us what their findings are, what their interventions are. So it's very well organized, actually.
Well, that's very helpful. So are there specific protocols or drills at the hospital, that help the team stay prepared for these high-stress trauma cases?
Yeah, we do some good drills. We do some disaster drills. We do mass casualty drills.
Yeah.
We actually just did one where we had some of our employees, they put a little fake blood, blood on and things like that, and they were dressed up, and they all came in as patients, and then to make sure, so that the ED wasn't overwhelmed, but then they were able to triage people appropriately and where they have to go and what they have to do. So we do them in collaboration with disaster management in the hospital, and we do those types of drills, as well as everybody does their own training for like advanced ATLS and TNCC and things like that. So. And education's big.
I could speak firsthand. I participated in one of those drills. They were great.
It is, yeah. I mean, I think it's very, very important to do so, because you could see how on any minute the ED could be turned into this big mass casualty, and you have to really be prepared, and everybody has to know what their role is. So it's very important to do those drills. Yeah.
So how many times a year would you say you do those?
We do it at least 3 times a year. I mean, we do the big one once, and then we have other little ones. Sometimes we do tabletop exercises and things like that, but we try to do it at least 3 times a year.
That's great. Yeah. Always prepared.
Yes.
Okay, so how would you say that the biggest challenges that trauma teams face, and how do you overcome them?
I think it's crowd control.
Crowd control.
I think it's because you have think about it, when the trauma comes in, you have patients that are already there, you have some patients that are waiting, you have family members that are already there. Then they come in, and if it's something that's the police are there, EMS is there, family members are there, so, and then we're all there. So I think crowd control is somebody taking control of the situation, which we usually have somebody in charge that is able to really delegate people, because everybody knows their role. I don't think that that's a challenge at all. I think it's just getting people to kind of step back. While it's a teaching hospital and we want everybody to be able to be involved, you have to be able to know your role and to be able to step back. So I think crowd control is the biggest thing. I mean, you might have something different from your end.
I mean, no, definitely. I mean, there's definitely a lot of people, especially if it's a level 1 activation, when you have seriously injured patient, and everybody's there, and everybody wants to help. And obviously, you want to kind of make sure everybody has their roles assigned and know what they're doing. From a physician standpoint, it's making the diagnosis. It's figuring out who the seriously injured patients are, and what interventions you're going to do. That's really the gist to it, because you don't have much time. That golden hour or golden minute, those diagnoses have to be made right away. And if you miss them, then the outcome is not going to be good.
How would you say the technology or, recent innovations have improved trauma care during this crucial period?
At RUMC, the new emergency department is state of the art. I mean, it made such a big difference. I mean, not that the old emergency department, I'm not going to say anything. We saved a lot of lives, I will say that. But everything is state of the art. We have everything and anything that you want at a reach.
Yeah.
For us, we can give more care in a bigger area, a nicer space. We give. I think the technology is state of the art, and it goes right up through our brand new operating rooms. Yeah. Also, looks like something out of a TV show. Like they're absolutely beautiful, and they're all state of the art. I think that they have a lot of robotics. We do a lot of things like that. So, it's been wonderful, and I think the transition into the new ED has been very good for us and very good for our patients. Yeah.
And to have the surgical pavilion right directly above the ER.
Yeah, we have in the back of the trauma room. There's elevator.
Special elevator
goes right up. Yeah. As soon as you come out of that elevator on the second floor, you're right at the trauma OR. So minutes count, and that'll take us. Saves a lot of time.
Right. Yeah. I think it's a very large investment for the hospital. We built a new emergency room and new state-of-the-art operating room. And it's an investment in the community. It's really. You don't need to leave the island to get the best care.
No.
You can get it right here, and we've put in a lot of money, a lot of effort, and gotta thank our CEO and the board of directors for doing this, because it's a lot of work to get this built. It took some time, but we opened last year.
Yeah.
And it's really great for the patients. It's great for the community.
No, the state of the art care is definitely.
Yeah, it really is. And I mean, you're at the worst time of your life when you're in the hospital. I mean, it's just, but to have just the comfortable surroundings and the everything that you need right there, it makes a big difference in somebody's stay and in how they're going to do throughout their stay. So It's a really big. It's beautiful. So if anybody hasn't seen it,
Right. Not
come
as
as
a
a
patient.
patient.
But
but it is. It's state of the art.
It is.
Yeah.
It's beautiful.
Yeah, it really
Absolutely.
is.
No,
Yeah.
we're very, very grateful to have
Yeah.
that, on the island and not have to leave, like you said, because we have expert care
Yeah.
here, for our community. Okay, great. So can you share any recent, case studies where innovative techniques or protocols, significantly improved patient outcomes?
We always have innovation where, every patient that comes in, just looking at the patient, like I said, just trying to figure out how, if they're seriously injured or, if they're okay. And, as far as technology goes, for trauma, there's no robotic surgery in trauma because of just the emergency of it. So it's kind of, old style surgery.
Yeah.
That's what I would describe it as. It's actually, it's been there, for hundreds of years now. And, obviously with the new technology, for example, we have chest x-rays available at the trauma bay. And we have the CAT scan, right there. It's available, but, there's no replacement to good old medicine. And I think, that's what we do. We take care of the patient.
Yeah.
And I think for us, we looked into like the hours that it takes us to get a patient from their injury with a fractured hip to the operating room. So we did a lot of study and we looked at data. I mean, trauma is data driven, really.
Yeah.
You see what comes in and what we could do better. So we really saw that we could improve that getting them up to the operating room faster.
Yeah.
And we've done that. We've cut our times in half. So
Wow.
you come here and you get up to the operating room immediately. If not, I mean, it's not a long time, and that has improved outcomes, and it's improved length of stay for us. It's decreased their length of stay.
Yeah.
So, which is always good. Everybody wants to go home. So, I mean, that's a good case study for us that we looked into, and we do that all the time. We're constantly looking at our performance and our data and seeing how we can improve it and coming up with ideas. So,
Yeah.
that
Do
was
you use AI at all in any of that, data to
we haven't yet.
I don't want to be replaced. I mean,
Yeah,
listen,
I don't
I know
No,
AI
not to
is
replace you.
AI
No,
it's
we
gonna be
haven't.
hard for AI to operate in the trauma.
Yeah.
But I mean, I don't know what the future holds. Who knows?
I think it's better
for the
to-
critical data and things like that? Or
Yeah,
maybe,
well, the data maybe, but I think good old fashioned. You want to talk to doctors that have
Yes.
experience and that they're that and
Chatbot.
get their opinions and there's what their experiences to really see how you can improve it better. I mean, I think that's what it's about because they come with a lot of education and a lot of wealth of knowledge. So you want to really that they're our AI is really we go to them.
Yeah.
So. Not yet.
Got it.
but I mean, there will be applications. I'm sure. I mean, people are going to come up with ways to use the technology to improve the patient care.
Yeah.
We have to think of something.
Yeah.
I'm sure we can figure out ways to implement it.
Utilize it, right?
Yeah.
Okay. So what role does the psychological resilience play for trauma teams, working in such high pressure environments? I can imagine that you
I think it's rough on a lot of them. I mean, I think that's why lots of times there's big turnovers in trauma centers because it's a lot on people. So we've done. I think that the staff and the administration in the emergency department really tries to help because especially when we have a case that that is extremely emotional. Yeah. We also have brought in a dog. We have
Davy Jones.
Davy Jones.
Yes, he's great.
So, I mean, lots of times I've gotten a call from the AVP of the emergency department saying, look, the staff really could use him. And thank goodness she lives up the street that has the dog, so she'll come and help them. And you know what? It really does make a difference. I mean, it's just something little that we can do. It's not easy because most are mothers and fathers down there. And to be down there and watching, something the worst of the worst of somebody losing their child,
Of course.
it's not easy for them. So
very heavy.
It is. And so we do have a lot of, things that are available for them, some counseling and things like that if they need. Down there, they're a tight-knit group, and I think that they just are easy to lean on each other. And when they go through something like that, the dog definitely helps. Yeah. But, talking about it and things like that, they're very good. The administration of the ER is very good down there. And in the hospital in general, they're very good in getting people anything that any type of services or help that they need, especially when they go through something like that. Because it's while it's a terrible situation for the patient and the family, it does. It's taxing on the staff too. Yeah.
What do you both like to do to decompress after a stressful day in the ER?
I like to go home.
I like going. It's funny because I was going to say that. I like going home. Sometimes it's long days. I do like what I do. If I didn't like what I was doing, I wouldn't be able to do it.
Yeah,
agree.
I mean that's the bottom line for me. And I enjoy taking care of patients, and in those critical situations, it's become easier for me.
Yeah.
And my decisions are more clear cut at this point. So for me, it's really satisfying if I can really help someone. If you go home with that feeling, I think that the stress goes away. Stress is when things don't go well. That's the stress.
Yeah.
When things are going well, there's no stress.
Agree. Yeah, I like to go home and just kind of you have to separate the two. I think from it.
It's hard, I'm sure, to not take it home. But
luckily,
with you.
it's a good place to work, and it's a good job to have, and it's I like what I do. Also,
You have to
keeping the
in a
program
field
going.
like this.
Yeah,
Absolutely.
It is.
Any advice for our final question for maybe some aspiring trauma medical professionals?
I think it's just about educating yourself and staying on point with the latest and the greatest. You have to want to be there. You can't go into a situation, especially as a surgeon, like he loves what he does, and that's why he's so good at it. I think that's what you have to do. You have to be able to really like it, and I would say even you have to love it. And so that would be my advice. If you don't find that that spark or that want to go back, then maybe that isn't for it isn't for you. But luckily for us, we have many trauma surgeons with us that at RUMC that they do love what they do. So
Definitely.
No, I agree with Tara. You're good at it, but you have to like doing it. You also have to have certain personality. I think but you're gonna figure it out. Like if you're in the field, if you don't, it's not gonna take you long to figure out you don't like it. So people that the trauma surgeons that we have, they really all kind of like me. They enjoy doing it, and that's part of their life.
Yeah. Like to be on your toes.
Yeah.
And ready for anything, right?
Exactly.
Well, I would like to thank you both so much for joining me today and for all that you do to keep our community safe and well. That about does it for this episode of RUMC Connections. For more information about RUMC's trauma department, people can call 718-818-2942 or visit rumcsi.org. Thank you again for joining us.
Thank you for having us.
I'm Meredith Gaskins.